decided to. Okay. All right, last session before we have some interaction. So I'll try and keep everybody awake. So we have, I think that if you can remember all the way to this morning, Boyelwa showed you a picture that we are doing work at the district level that interfaces in part with province and then at national level. So we have two main areas that from a QI perspective we've been supporting national, and Taryn's obviously been indicating some of the support at a sort of national level, but not necessarily with National Department of Health. So we think that this is an immense privilege that in fact all the other district support partners don't have the opportunity to do, which is to actually take the granular information that we get on the ground and be able to interface that with what's happening at national level, the kind of policy, decision making and implementation practices that come from national. So one of the first aspects that we were asked to do was around the DIP process and the 1990, and we were asked to support the National DIP Technical Working Group. And initially we were really just presenting findings that we were seeing on the ground and being able to interface those with what was being proposed at national. And I think that we can all safely say that whilst we all had this wonderful ideal, that those of you will remember, provinces were quite upset because DIP went directly to districts and wanted information to be supplied directly from districts. Districts were under extreme pressure to submit data that they hadn't validated yet. And then when DIP came to the districts and to province, then the data they presented was not the data that you have. So there were all sorts of challenges. But what was helpful was to be able to see on a global scale what's happening for the most part. But of course, we always start with, is the data valid? And then what do we notice? So this is slightly outdated data, but I just use it for illustrative purposes. So this is the National Adult 1990 Cascade. So these are the estimates of the people living with HIV, those who know their status, so that being the target, and this being what's done. So you can see testing is pretty good nationally. Total remaining on ART is quite a bit below the average. We're only achieving 57% there instead of 90%. And the viral loads done and viral load suppressed. As you can see, viral load suppressed only because its denominator is of viral loads done, right? So if you're not meeting your viral loads done, then obviously that can look better than it really is. So, but what's interesting here is it shows us just how far we've got to go. And remember that because each of these, from a 90 perspective, in fact, what Taryn was presenting was the little half man, in fact, is not the case because the 90 is in fact the denominators of the previous indicator. So in fact, it's not, we're not ending up with 10% at the end. We're actually ending up with much less. So just a reminder of that's one of our biggest challenges with looking at 90. So this is Eastern Cape. This was 2016, looking at people living with HIV, so 740,000 was the estimates, and there were lots of science and research and evidence gone into the population estimates, and they've been changed a few times. I'm not even vaguely going into that. You can ask Paseko if you want to understand about the population estimates, but in terms of testing, not too bad, but you can see the same pattern, and the same pattern is countrywide. So it's not a unique problem to Eastern Cape. It's a problem for all of us, all around the country, that it's there that we start to lose. One of the problems, similar to everything that we've already discussed today, they know their status, fewer viral loads are done, but of those that are done, my concern is that of those that are done are because those are the compliant patients anyway, is that the viral load suppression rate is pretty high, and then where are the dots not connecting, and I think we've discussed some of those. So the whole point of us doing DIPs and QIPs and all these lovely acronyms that we love to produce in medicine and public health medicine is we're really trying to say between what we plan to do and what we actually do, there's a gap, all right? And we're trying to bridge the gap. And that was what DIP was really trying to do, was bridge that implementation gap. But it wasn't as effective as we'd hoped. Okay, so there are major problems. Some of the problems were that we have kept a vertical siloed approach. Okay, So something that, that I wanted to mention earlier is that in a sense we can almost think part of our challenge is the syndemic framework, right? So that we have these multiple epidemics that all act in concert together. So when we're talking about HIV, we're actually not just talking about HIV, we're also talking about TB and substance abuse and poverty and multiple other epidemics that infect. So that's one of the challenges with then dealing with it on a vertical silo approach. The data is still suboptimal because of course we were getting data quicker to try and be live, but it was actually unvalidated and actually wasn't very helpful in the end anyway. It couldn't really be used. The plans were never integrated with DHP. So we had a DIP over here, and then we had our DHP over here. And that doesn't work, ever, all right? We know that if you have a performance management system that doesn't match your strategy, what's going to happen? Is your strategy going to happen? No, because you're measuring people on that one. So it's a huge, that really is a problem. It also significantly omitted provincial input, which caused all sorts of challenges. It was in many parts driven by donor agencies and seconded staff, so that it wasn't integrated. So that's what we spent the last discussion talking about, being integrated into what we do every day. That it's not about whether it's Orem or whoever was, okay, it's about actually it must be the department, right? And that's what we're talking about today. This is not about Succeed or Stellenbosch or WUSU. This is about Eastern Cape health and that happening. It also was never focused on an improvement approach, so there wasn't a how-to. So we continuously analysed what was wrong and where the problems were, where the bottlenecks were, but we actually weren't putting necessarily particular improvement actions in place to fix it. All right. So what happened towards the end of last year, or the last 6 months of last year, and this is where Lesego Mawela comes in, and he introduced himself this morning. So he's based in Pretoria as our technical advisor there. Is put together a workshop looking at what's happening on the ground with stakeholders, particularly around HIV. And guess what they came up with? The conclusion of the workshop was, we need a national strategic framework for quality improvement. So that leads me on to my next thing, is that guess what? We'd already been asked to do a national quality strategic framework by the National Department of Health. Wow, one part of the National Department of Health isn't talking to the other part, which are a few offices down the passage. I am teasing, but I am kind of right, aren't I, Lesego? Okay. So we were asked to do basically, I don't know whether, are all of you familiar with the National Policy on Quality of Care of 2007? Raise your hand if you know it, seen it. Okay, like 2 people, right, 3 people. So it was very poorly distributed. It was a very nice sort of theoretical la-di-da article, lovely to write a document like that, but actually didn't say anything about what we must do. All right, it just said about what we must kind of be, but didn't tell us how to be. So what the Chief Directorate of Quality Assurance recognizes this is a problem. Okay, so we asked us to review it and to take a situational analysis on implementation of quality in the country, and then wanted us to actually develop a strategy. And we gave lots of advice after doing some research and looking at what the literature says to say, actually, the approach that most countries are taking, including WHO, and the guidance of all the big expertise around the world, is to not look at a strategy, but a strategic framework. In other words, a framework in which you can hang all the bits and pieces. So all these lovely policies that we've got, because in fact we've got lots of quality policies, right? It just depends on how you classify them. Clinical guidelines, APC, all of those are quality policies, but they're just not included under quality yet. We don't figure them as quality. Ideal Clinic, all of those initiatives are quality initiatives, but they're just not hung together, so we can't see the interrelationship of them. So all of these things came to be, and it was just so fortunate that Succeed happened to be involved in all of them at the same time, that we could show that actually it was worthwhile to synergize all of this. So as I've indicated, that the DIP process had this workshop that we decided needed a national framework. We've been asked to do the work in December 2016. And then last year, the first National Lancet Commission on High Quality Health Systems in the SCG era, I got it right without stumbling, was launched in May last year. So this is born out of a Harvard initiative looking at a global commission on high quality health systems. Most of the Lancet commissions up until now have been on clinical work, so on surgery and other aspects. So this is really the first one looking at a big health system approach. But all we're looking towards a national quality strategic framework. So for us, we've been encouraging that we ensure synergy and alignment, and in fact we are connected on all three of these areas, and in fact we've appointed and taken over Lesejo's appointment, and so we're making sure that these are all aligned. We also represented on the last commission as Prof. Lillian Dudley was appointed as commissioner, and I've stood in her place while she was on sabbatical. So there's a number of reasons that we need a quality framework. One of the key imperatives, you can read while I'm talking, but I'm not going to go through it in detail, is really that actually it's the impetus for driving universal health coverage. So if we don't get quality right, in the words of our DG, if we don't get quality right, NHI is doomed to fail. If we don't get healthcare quality right, NHI is doomed to fail, because all that we're doing is replicating what we've got now, but just shifting the deck chairs on the Titanic. We all know that there are lots and lots of quality initiatives. So I just mentioned Ideal Clinic, National Core Standards, Best Care Always in the private sector and in some of the public sector hospitals, even something like Baby Friendly Hospital Initiative. All of those are quality initiatives, right? They might not all be quality improvement initiatives, but they are certainly quality initiatives, whether they're quality assurance or quality control or some are quality planning aspects, but they're all around quality. But this is how the person on the ground, our nurse or facility manager, is experiencing them as just random things, right? Random things thrown at them, feeling completely overwhelmed by all these things. So the nurse practitioner on the ground is not seeing that Ideal Clinic is connected to National Core Standards, is connected to NHI, is connected to DIP, right? And have all of you seen the dots that they are connected? No, probably not. Okay, National are battling to see their own dots connecting all of them. So the idea is that a framework would help connect these initiatives that are already there and try to synergize and harmonize so that people don't feel overwhelmed on the ground. Okay, so we're busy working. This is work in progress. We've done a literature review, so we've heard a lot. That we make sure that we don't go and repeat what's already been done before. So we learn from where others have learned. So we've gone through definitions to make sure that we all have a common understanding. So even in our previous quality policy, there was a very vague definition, to be honest, that didn't really unpack and use anything that is used that is cited repeatedly in the literature. Similarly, there are the dimensions of quality of care, so we then stipulate that so that we don't end up all talking about terms, using terms we actually don't have the same understanding, the common understanding of those terms. The quality framework, and then of course defining quality improvement. So quality of care is not exactly the same as quality improvement. We obviously are wanting to improve as time goes on. There are elements of quality, not just, most of our initiatives up until now have focused on quality assurance. So putting a standard and then checking whether we meet that standard. So that's National Core Standards. Ideal Clinic started off like that, didn't it? But then it didn't say what happens when you reach the standard. The whole idea is that we should keep improving. Okay, so these are all the elements of quality, the Durand trilogy, but actually we really need to be making sure that we encompass the full spectrum of quality. So what the Lancet Commission have done is now taken it a step further and said often when we think of quality, we only think of it in terms of a clinical scenario. But in fact, what we really need to be doing is focusing on what are the elements of a high quality health system. And so we started to take the aspects like the World Health Organization building blocks and a number of other aspects and add it into this beautiful, rather long and wordy, but certainly comprehensive definition. So it includes aspects of equity, includes the full spectrum of treatment, of care, all the way from protection, promotion, prevention, all the way to rehabilitation. Accountability, leadership and governance, people-centered, responsive, comprehensive, must have quality outcomes, must use information. So you can see all our building blocks coming through, and all the things we've spoken about this morning are emerging in this single definition. We must have equitable allocation and distribution of resources. So we spoke about resources earlier today. And obviously non-discrimination and equality to all, and collaborating across sectors. As we know, health is in fact very little determined by healthcare. It's much determined by other sectors. Education, roads, infrastructure, sanitation, water, etc. We don't mention water in Cape Town. All right, so quality framework. So now we're saying, okay, so now if we need a framework, are there some out there? And there are lots out there. So this is the World Health Organization. You can see some of those elements emerging. I'm going through them very quickly. OECD has some lovely stuff talking about health, not the absence of disease, but the overarching aspect of health, alma ata definition, the non-healthcare determinants of health, health system performance, all the aspects relating to the dimensions of access and quality, as well as health system design, so efficiency and effectiveness being key. Then we look at something like Peabody, which includes things like political factors, cultural factors, social factors, institutional factors. So now suddenly we're starting to think more about our community and population aspects. We start looking at something like the Van Olmen, which has the whole context and looks at populations explicitly. And you see that it has a specific aspect around values and principles. So now we're starting all the way from NHI explicitly states that we want access for all and we want equity. So now we put those in as explicit values and principles of our health system. We did a whole number of reviews of, specifically we looked at, the literature's obviously, there's lots in high income countries. So we did take some of the best, the best practice experiences, but we specifically looked at countries similar to our own. So we looked at BRICS, and then we also looked specifically at some sub-Saharan African countries about what their experiences are. And there's some great experiences, but I'm not going to bother you with all of them. So we can learn a lot. This is a really nice kind of framework that has contributory measures that are all the way down at the facility level. Now we often tend to focus at facility level, but that's not the whole health system, right? And maybe some of our 1990 challenges are that we don't have the system approach. We don't have the system aspects included. And then here you see the system level indicators. And then you see all the way up to what are the government goals. It's about people living healthier, longer, independent lives and having economic growth. So we can start to see that our NDP can then be part of our national strategic quality framework. China has some really interesting bits around institutional and financial environment with better health outcomes, as well as then reforming their service delivery. So it's very much a reform agenda informing their framework. Metrics and measurement, of course, as we've said, if you don't measure it, it ain't going to happen. So you have to measure it, and so we started researching around metrics as well. And of course, we're very used to the clinical level indicators around the cascade. So, and the cascade, of course, can be applied to non-communicable diseases. It can be applied to all sorts of aspects. So those are really helpful, but they're not the whole picture. The whole picture needs to include all system level aspects at the macro, meso, and micro level. So it needs to be at all levels of the system. This one is a way similar to the OECD, which actually puts the metrics into the framework. So you can see the measures of outcomes and system performance, socioeconomic determinants, health system inputs, etc., and stages of care, so the cascade, but actually has the metrics almost built into the framework. So that's very helpful. And then of key, we just started talking about it just now, is aspects of patient involvement. So we actually need to hear the voice of our patients and our population and our communities in this. This is not to be provider-driven, but actually patient-driven. And so the NHS has this very interesting component. We tend to look at patient-reported experiences, but they also talk of patient-reported outcomes. So patients actually give us feedback around whether they think that they have been cured, whether their pain has been relieved, whether their mobility has improved, etc. And then also incident reporting. So we've spoken about safety of patients, but in our system, it's still a very passive reporting from health workers. It's not from patients. Stakeholder mapping, obviously we need to make sure that stakeholders, that we consult all stakeholders. So I'm quickly going to whiz through. We've had to do a policy analysis. We're in process. So we have a lovely framework of looking at all these different types of policies and how to categorize them, looking at a policy review, mapping all our wonderful legislation. We have tons of legislation and even more tons and mountains of policies, which are all actually really good for the most part. Our real problem is what? Implementation. Okay, so yes, we need to know this, but actually we need to first of all make sure that they're all harmonized and congruent with each other. You know, we can't have this situation that we've got with different ages of consent throughout multiple different pieces of legislation. But so that's just as one example. Okay, so this is now it. What are we doing about it? So we've started to take the elements of frameworks that work within the definition of the high quality health system. and as well as the foundational pillars that have emerged out of the literature, and use the definition, and we've got some options. So this is what the Lancet Commission came up with, looking at the von Ullman adaptation, looking at the values, the context, leadership and governance, input, service delivery, outcomes, and impact. And then what we started to work with the National Department of Health and presented this to the Lancet Commission is to say, who's recognizing this in the middle here? This is the cascade, right? So now we've got a cascade that everybody recognizes, but to say it's a component part of a quality framework, but it's not the whole picture, because there are other parts to the picture. So if we go to the end, we need to make sure that we're making an impact, because it's not just about cure rates. We actually need to be making sure that in our actions, we are actually reducing incidence, we are reducing morbidity, mortality, we are increasing life expectancy, which is an increase in qualities, which are part of our NDP goals. So we need to go all the way there. Then coming back to this side is we need to say, well, our context is important. Our socioeconomic determinants of health determines our needs. Our design of our system is around our needs. We have our population needs based on burden of disease, and then we have all of our WHO building blocks, including explicitly our regulation policy and standards, as well as, which is not included in WHO building blocks, population and patient engagement. So specifically and explicitly included there. And then the idea is similar to the OECD framework, that we would have metrics along the dimensions that would then feed into each of these. So each of these red blocks would actually have a whole bunch of indicators that would then match, that would then metrics that would go into that we could then measure, are we achieving our high quality health system? So just to reiterate then, we're working between these three elements of the DIP, which is now the route that the HAST and TB, maternal and child health, and PMTCT will be routing through to sit underneath this umbrella of a national quality strategic framework, and then for us to continue working with the National Department on that, and to try and bring all of the different DDGs programs into, so services, horizontal services and vertical programs will then all be brought under the umbrella of the National Quality Strategic Framework. So that was a whistle-stop tour through some lengthy work, but that hopefully gives you a little bit of hope that there's some nice things happening, some nice thought process happening. And that will hopefully help people on the ground to make sense of the things that then come down to them on the ground. All right.
Okay, that whistle-stop tour. It was hectic. You're doing wonderful work. It looks very complicated, all those diagrams.